We got to see so many different professionals and parents, and here's some great insights from legislators. And from the feedback that we've received, it was very insightful for a lot of people, and at the same time, a lot of questions and conversation, which is perfect. So again, if you're here, please let us know where you're from, and at the same time, what did you attend yesterday, or what are you looking to attend today? Again, to get more information for your child, to understand these subjects a little bit more, we'd really like to know in the chat. And again, my name is Nick Lutton. I'm the program manager for Family Voices of California. And each year, Family Voices of California puts on this health summit, which is a 2-day event where we bring together consumers, parents, as well as different organizations to make sure that children and youth with special healthcare needs are put at the forefront. And we're extremely excited that you're joining us for the second day. So I want to go ahead and open. And I want to thank everyone that joined yesterday again, and a warm welcome to those who are joining us today. Your presence here is a collective endeavor to improve healthcare access and outcomes for children and youth with special healthcare needs, and I appreciate it, and so do the other agencies that are involved. Yesterday, we had the privilege of hearing insightful presentations and engaging and meaningful discussions that challenged us to think deeper and collaborate more closely. We kicked off the day with a powerful keynote from Senator Anthony Portino and enjoyed a series of enlightening plenary sessions and breakout sessions. Each conversation brought to light unique perspectives and solutions, truly embodying the spirit of shared knowledge and community. Today is going to be another day full of opportunities, and we'll begin shortly with a keynote address by Jim Frazier, which I'm sure will set a motivating tone for the rest of the day. Following the keynote, we will go ahead and dive into our morning plenary session on enhanced care management, led by Mike O'Day, and a panel of experts who will be able to share their insights in regards to a complex system of care. Throughout the day, we'll explore various topics across breakout sessions, including dental care, in-home supportive services, legislative advocacy, and transition to adult care. These sessions are crafted to address the practical and pressing issues that we all face daily as parents and consumers, offering strategies and resources that will empower us to make a difference. Our heartfelt thanks goes out to our sponsors, whose generous support reflects a deep commitment to our vision: the Lucille Packard Foundation for Children's Health, the California Children's Hospital Association, CalOptima Health, Children's Specialty Care Coalition, Pediatric Day Healthcare Coalition, Tri-Counties Regional Center, Lucille Packard Children's Hospital Stanford, and all of those who champion the voices of families. And now it's my honor to introduce our next speaker, who's going to kick us off, Gina Stable, who's the Director of Programs at the Alpha Resource Center. Gina's dedication and expertise have profoundly impacted our community, and we're thrilled to have her insights today. So please join me in today in welcoming Gina.
Well, thank you, Nick. I'm happy to be here. I promise to behave. Good morning, everyone. Again, thank you, Nick and Family Voices of California, and really everyone involved in putting this amazing summit together. This is absolutely one of my favorite events of the year. It really is, for us all to come together. It's my absolute pleasure to welcome all of you to the second day of the 2024 Family Voices of California Health Summit. Again, my name is Gina Stable. My life job is being the parent of 4 amazing humans, and I am also the Nona of 8 amazing kiddos. They're the love of my life. One of my sons has a physical disability, and my youngest son, my baby who's not a baby anymore, who just turned 22, has Down syndrome. In my day job, I serve as the Director of Programs at the Alpha Resource Center of Santa Barbara. I'm thrilled to see so many familiar and new faces gathered here today, as we do every year. For those of you who may not be familiar with the Alpha Resource Center, we're a nonprofit organization. We're dedicated to empowering individuals with intellectual and developmental disabilities and supporting their families and caregivers across Santa Barbara County. Our team includes family members, just like many of you on here today, who have both lived and professional experience. Take a breath. At Alpha, we believe in creating opportunities for growth, education, and advocacy, ensuring that everyone we serve can live fulfilling lives. We are proud, super proud, to be an executive council member agency of Family Voices of California, an organization that does remarkable work in advocating for children and youth with special health care needs. Together, we strive to make significant impacts in our communities through collaborations and shared initiatives. So thank you to all of the executive council member agencies. All right, so yesterday we had an incredibly engaging first day filled with insightful presentations from a diverse group of speakers, ranging from dedicated professionals to inspiring parents who shared their wealth of knowledge and experiences. The conversations that took place were not only informative, but also deeply moving, reminding us all of the vital work we are doing together in the community. I also heard the chat was amazing, so keep doing that. Let us hear you, participate. It's so great when we see this. Today promises to be even more exciting. We've lined up more esteemed speakers and topics that are directly relevant to the challenges and opportunities faced by families and professionals alike. We are set to dive into discussions that will resonate with each of you, aiming to foster understanding and spark further collaboration. I want to express my heartfelt thanks to all of you for joining us today. Your commitment to improving the lives of families dealing with special healthcare needs is what fuels this summit. Let's carry forward the momentum from yesterday and make today even more productive and inspirational. So thank you for being here. And let's have a fantastic second day. All right, now to the good part. It is my distinct honor to introduce a true advocate and tireless champion for those who are often left behind, Jim Frazier, a retired California State Assembly member. Hi, Jim, who has dedicated his life to serving and uplifting the most vulnerable among us, particularly children and youth with special health care needs. From his tenure representing California's 11th Assembly District to his profound personal commitment following a family tragedy, Jim has been a formidable force for positive change. His legislative career, spanning nearly a decade, was marked by unwavering support for the developmental disability community. Woo! Taking a breath, I'll let the interpreters catch up. Including his pivotal role as chair of the Select Committee on Intellectual and Developmental Disabilities. This committee, formed at Jim's request, thank you, Jim, sought to bring long overdue attention and resources to one of California's most underserved groups. In addition to his legislative achievements, Jim co-founded the Network of Care, serving hospitals statewide to ensure that parents have the support they need when their children face health crises, like many of our children do, many of you on here. His ongoing work with the ARC of California, which we get to do with him at Alpha, as the public policy director, underscores his continued commitment to advocacy, ensuring that the voices of those with developmental disabilities are heard in policy discussions and outcomes. So thank you for that, Jim. Recently, Jim was a key partner with the Family Voices of California to put on the 2024 Disco Capitol. This pivotal event brought together hundreds of advocates, consumers, and change makers to meet directly with their legislators in Sacramento, advocating for transformative changes and fostering direct community engagement. As we welcome Jim today, we do so not only to acknowledge his past contributions, but to also inspire our continued commitment to the causes he champions. Please join me. Let's see those reactions in welcoming a true leader and unwavering advocate, Jim Frazier. Welcome, Jim.
Wow, thank you. I don't know how to respond to that. But first and foremost, I want to thank Senator Portantino for being your keynote yesterday. He's an amazing advocate for the population in California, and I've had the distinct pleasure of working with him when I was in the Capitol, and his support is unwavering, as his staff also. I want to also thank the very kind and thoughtful sponsors for sponsoring this summit with Family Voices. It's very important that we have the private sector support on being able to move forward with our mission of support for this vulnerable population. Excuse me. Also want to thank Nick, who, again, I had the distinct pleasure of working on the disco event in the Capitol a couple of weeks ago. I will tell you that Nick can dance. I saw him, and I appreciate all the hard work. I don't know that this, actually, I know it wouldn't have been successful with all the meetings and all the hard work that Nick and his folks put into this event for the advocacy day in the Capitol. And it really did move the needle. People in the Capitol were talking to me and saying, hey, I saw your folks, and it was a great thing. So just really want to say thank you, Nick, for the partnership and the collaboration. It was an absolute outstanding outcome. So, one of the things that, I want to be able to share with you is the reason I do this work is because of you. The inspiration that you give me is unbelievable. You guys are my heroes. And so, I just keep moving the needle by also the suggestions and the advice that you give me to be able to kind of use my political capital, I guess, that I kind of gained while I was in the legislature, and want to continue that work, knowing that we have much to do. As you know, and I'm speaking to the choir, and after years and years of rate freezes and for our population, I was able to, in 2015, help get the rate study commissioned. And we worked on that, trying to public support and public input to be able to increase the rates for the providers and also the downstream, employees of the providers. And then, the implementation took place in 2021, so it was a monumental achievement, but again, it was phased in, and it was just not recognizing that the immediate need was now, and that we needed to be able to focus on making improvements to the system, and it costs money. And so I was dismayed this year when the governor actually proposed delaying the final implementation of the budget with the DDS process. And so we've been working on, for the last several months, meetings with legislators and chairs of committees, trying to increase awareness of what will happen if this delay occurs. And so hopefully in the next couple of weeks, by May 14th, the governor has to propose the May revise. Hopefully we'll have good news coming forward. So please keep your fingers crossed, and don't stop connecting with your legislators and or the governor's office on how important this is to you, to make sure. I just want to, share with you that during my tenure there in the legislature, during COVID, this is just kind of another example of what it takes to be, a champion or a fighter for the population, is that during COVID, the vaccinations, our population was put it down into tier C. And I happened to serve on the Health and Human Services Sub-1 committee. And I was very vocal about the imminent need to move the population up to tier 1, and hope it happened, but I hope I was a part of that, making sure that the population was moved up into the vaccination tier A. And so that I was very happy with that being able to happen. As was mentioned by Gina, I was the chair of the select committee that I asked to be able to form for the select committee for the intellectual and developmentally disabled in California, and was able to tour throughout California with hearings. We did 8 hearings throughout California, from San Diego up to Redding, listening to stakeholders and actually helping increase my awareness and how I could be effective and a better legislator going forward. And it was an amazing experience with that. In that process, in the time that I was in the Capitol, I actually carried 31 bills on behalf of the population. Not all of them successful, but leaving a mark and increasing awareness on that proposals. But we have a new champion in the legislature now, Assemblymember Stephanie Nguyen, who is distributing a letter throughout the legislature to deny the governor's proposed budget cut / delay. And I'm very proud of her efforts. I think we were seeing over 53 signatures of legislators, so we're continuing to try to help her get more signatures on that going forward. But Stephanie will be a force to be reckoned with. She is a mom with a child with a developmental disability, and so leading by example in her role. I'm very proud of her, and I'll give her every kind of effort that I can in my role to champion the cause. Been working, in this capacity as the director of public policy for the ARC of California now, which I'm very pleased that I was able to join the organization. And for the first time in the 50+ years the ARC has been in existence, we're carrying 6 bills or sponsoring 6 bills on behalf of the population and trying to improve the quality of life. We're doing the family wellness program to be able to support families and siblings of the participant in the regional centers. We're doing a Medi-Cal bill to streamline services so preventative care can be on the forefront of the dental component in people's lives. We're also doing what else? Oh, we're also doing a bill to increase training for the DSPs in the provider world through the community college district. Training and certification process so that they can make more money. And then also Darby's Legacy, which is a bill that creates the opportunity for training of not only the hospital staff, but also the regional center staff on how to promote Medi-Cal waivers to medically fragile and developmentally disabled children when they're born, and getting them in a pathway of compassionate care. And so we're working hard on getting that done. It's just an ongoing thing. And what I would, like I say, in the role of advocacy, as a whole with all of you, and you're all on here, and I can't thank you enough for engaging, because this is how things get done. And you're learning, and you're able to take this advice or this information and share it with others too. And so that is a role of advocacy. But in my world of advocacy is talking to the legislature and making sure that they are aware of issues that are of concern to all of us, that and I hate to use the word ignored, but basically not been a concern of the legislature or whatever you want to call it. But we need to continue to push the legislators, your legislators, on information on how they can legislate better for the population. We are their constituents. And if you have advice or ask for recommendations for legislation to create statute or a law that makes it a requirement, please do. And I mean, use my name. I mean, I'm a former member and a colleague of the people that are up there right now. And just say, I recommended that you talk to them about this issue. And if I need to follow up with a phone call, get a hold of me through the ARC, and I'll be more than happy to support you with any of your issues going forward. We have to support each other in this effort. And hopefully we can continue to do so. The master plan has been announced, and I'm hopeful that will be productive. And there's a lot of stakeholders involved that are experts in their field. And so I'll be making my comments from the public sector on how I think that I can be informative, but it's just a ongoing process of, and what I have to, again, as I keep going to the advocacy thing, don't give up. Don't let them wear you down. Make sure that you're that advocate, that they recognize, that they understand you're not going away, and that they'll take you under their wing and give you a hand and address the issues, excuse me, that you're looking to get done. With Family Voices, when I was in the Capitol, they were a formidable advocate, and they're well known. And it's the reason why things get done is the people that hang in there and won't give up. With that, I'm just looking forward to getting through this legislative process with the bills. I've been helping. We have, I think, 32 chapters with the ARC and the United Cerebral Palsy, and I have been working with my chapters on regional center issues, legislation, excuse me, and DDS issues, and just kind of a customer service role also to address the any of the issues that they have. And with that, Nick, I think it's opportunity for you and I to bounce each other back and forth.
Absolutely. And again, we just want to thank Jim for being here today. Again, obviously extremely busy, and I can't thank you enough for all the kind words. The Disco at the Capitol was a fantastic event, and it definitely showed what happens when parents, children, consumers, and community-based organizations get together for systematic change. And that's exactly what the hope was. And I believe we accomplished that goal through a shared, common interest. And so I want to thank you for taking the time to be here and to talk to all the participants that we have. And something that you said, and just to go back on what Senator Portantino had said yesterday, that I think would be interesting to hear from your perspective. How you had talked about, making sure that our population in the vaccine schedule was up there because it was something that was, again, in Schedule C, right? And I know in the beginning, that was a really big thing for everybody. We'd all been locked away for 2 years. And so it speaks, though, to a larger issue, I think, which is the legislature and the people that are in Sacramento or in our local offices maybe don't have not enough knowledge, but enough firsthand experience with children and youth with special health care needs, adults with special health care needs or intellectual disabilities. And maybe you could talk about what the impact is of things like we did at the Disco, where we put everyone in front of them, or even making those phone calls. Because again, from what my understanding is, and the way that I talk to parents and when we train parents through our project leadership program, is that any action is better than no action. But being there in front of them, you might be sitting in front of a staffer that has never had to deal with a child or a family member who might have a special health care need, or even the legislator themselves might have not had to deal with it. Could you speak to the importance within your time in the legislature and what that was like? And at the same time, how does that affect when it comes to personal one-on-one interaction or even those phone calls, like you said, to be a relentless advocate? How does that help further the cause of the advocates that are on here today? And what impact does it have?
Sure. And so one of the things I would say that presence is everything. A lot of the groups, and I don't want to disparage them for doing so, but they do a one and done. So they do their one thing during the year and then they disappear for the rest of the year. And that's hard because there is such a staff kind of transition. Nobody stays there very long in a staff capacity. So, as you mentioned it, you may meet with staff on an issue and it might get to the member and hopefully it does, but they move on. And so you have to continually advocate to that member, to that staff, to be able to move your message. And that was one of the things that everything that at the next morning of the day after meetings with my staff would take meetings and I would take meetings, we would have a debrief in the morning before the next meetings would start. So I would get who they met with and what came out. Make sure that when you're meeting with a staff member that they know that you have an expectation or an ask of them debriefing with that member. That you're hoping that your message gets moved to that member. A lot of people don't do that, and so when you come with with good information about how they can better legislate or how this affects you, it does tug at their heartstrings. I mean, they have to recognize that you're counting on them to be able to, represent you. So, I mean, it is definitely every time there's a contact, there is a some kind of acceptance that happens, right? That you are moving that member to understand more. And again, there's very little people that understand what our population goes through. Very little of them. And they'll all say they're very compassionate and care, but you've got to remember how many policy areas they cover, throughout that whole, what their responsibility is. And so you've got to kind of move it up as an importance level for them. And so one and dones, they do, make a mark, but continually calling, making sure that they have that information is imperative. And I will also say, one of the things that also is helpful is when groups or individuals talk to the member or staff and also ask, how can we help you? Sometimes the members feel like ATM machines. They're always out giving, okay, and being pulled from different directions. But when an organization comes in and says, how can we help you be more successful? That really helps. That really does make a difference. And it always put a smile on my face that somebody cared about me and how I could be successful too.
I love that answer. And again, that's one of the most interesting parts I think about not only advocacy, but being, a father and a parent and a caregiver, is that I learn the most, not from organizations, but from other family members about, how to help my child and how to advocate and how to legislate. And again, the people with all the letters after their words. I love that. I think it's great because, again, we want to hear from experts. But I find that parents and people that are in your position have certain things that, again, we don't normally think about. And like you said, that's a key one right there, which is, how can I help you? What can I do to assist you so that you can help me with, with my issue?
Mm-hmm.
And I agree, that's something that is not well known. And then at the same time, when you're constantly being asked for things, it's nice for somebody to go ahead and say, hey, how can I help you with you and your staff maybe to understand this more? Or what would you like me to do so you could get behind it? So I absolutely love that. One of the other things, and then I'll get to one of the questions that are in the chat, which I think is really important. So we span throughout the state of California, obviously, just like the ARC does, right? And so we have parents and providers all throughout, from Northern California all the way to San Diego. And one of the things that at Family Voices we talk about is the systematic change, right? Is making sure that people are involved in that systematic level, but at the same time, teaching family members and providers and consumers how to get involved locally and at their county level. Can you speak to how important it is? Because not all of us can get to Sacramento, right? Not all of us can. I would love to have taken my son to Sacramento, but I wouldn't have been able to because I wouldn't have been able to do my job. And it takes months of planning to do things like that. Can you talk about how important it is, whether it's board meetings or community advisory committees or just even the local legislators' offices, how important it is just to stop by and introduce yourself and what an impact it makes?
So, I started out as a planning commissioner in the city of Oakley, back in I think it was 2007. And I had been a volunteer at Special Olympics for, I don't know, probably at that point in time, 3 or 4 years. And so from planning commissioner to city council to mayor to state legislature, I would say that, to answer your question, anytime you have an opportunity to raise awareness with your city council, your board of supervisors, any kind of advisory committee, it's helpful. They represent you. There are opportunities to go to the next level of electeds and share that opportunity of help or ask for help. Is then, it's a kind of a chain, right? And so any and everywhere that anybody can advocate or ask for help is essential. I mean, again, locally, it does get to us. City council members, mayors, board of supervisors, we have all each other's numbers. And so it is a viable way, a conduit of information. And the other thing is, and it's hard for families, I absolutely understand this, but if the boards and commissions that you can get on to raise awareness is very, very important. Just like I serve with several members on the commission for improving interactions with the intellectual and developmentally disabled and law enforcement, there is several mothers on that commission who are balancing family life and also this commission duty to help that process. And one of the things I will say, I will defer to them as experts when it comes to, their input. That it's essential. And so and again, I'm not trying to, I know it's so tough, but the more people that we can get on these boards and commissions as experts for our population, the more we're going to be able to be effective. And I know it's hard. I really do.
Absolutely. And again, I appreciate you breaking it down because people look at systematic advocacy in Sacramento or Washington, D.C., and that's where everyone wants to start. And I totally understand that because that's where I wanted to start. I want to change the world, right? And I'm going to go in there and I'm going to speak to a senator and then they're going to change this bill because me and my family need it. And I realized once you catch the advocacy bug, right, you start joining all of these local groups and then you join these advisory committees and these boards and you continue. And then you end up joining too many and you have to go ahead and scale back because you catch the bug, right? But everyone wants to do the Sacramento and the DC thing. And I think that that's fantastic. We would never discourage anyone from doing that, but to gain great practical practice, by doing it locally and speaking in the smaller stage areas so that they could go ahead and get to that level, I think is really important. And like you said, you hear about it. So you've heard it straight there. Doing things locally gets heard up at the Capitol, which is exactly what it is that we're looking for. We have a question here that I think is going to really fit in nice because we have Dr. Glassman speaking this afternoon. And it says, hello, Jim. Access to dental care, especially for those with special needs dentistry, virtual dentistry, with RDH APS and behavioralists, special needs dentistry facilities, increased training and advanced care dentist with experience working with people who have disabilities. What does the Medi-Cal bill propose in order to facilitate primary care dentistry for people with developmental, intellectual, and behavioral disabilities? I know that you've worked on that with Dr. Glassman.
Yeah, and I am just absolutely thrilled to death that I was even had the opportunity to meet Dr. Glassman, because he is phenomenal in this role. After spending decades in and working with the developmentally disabled population, it just blows me away that we were able to craft this bill. One of the things about legislation is that if you try to take too big of a bite of the apple, you'll never get it through. So what we're doing is a very prescriptive first step is to be able to create training for registered dental hygienists to be able to go out from outside of the brick and mortar, go to day programs, go to any kind of facility, assisted living facilities, you name it, to be able to start the process of preventative care, and also have the remote capability to be able to do the video conference with the dentist. So it's a start in the right direction. Next year, hopefully, we'll be able to advance this process. And we're open to all opportunities and suggestions to be able to make it better. But, one of the things that I learned early on, as you mentioned about going in and change the world, I went in with big ideas in the beginning, and with these bills loaded up with, all of these grandeur wants and needs, and they never made it past the first or second committee because they were just too loaded up. And so, so that's what we're doing with this. It's AB 2510. You can look at it and get the terminology on leginfo.com and read the bill. And what's been really nice is we just had a committee hearing on it in higher education last Tuesday, and came out of committee unanimously. So we've been unanimous in every committee going forward, and it really is gaining support.
Yeah, absolutely. And I've had the pleasure to speak with Dr. Glassman about it. And again, he'll be doing our breakout session today, speaking more about it. And it's huge because dental care, obviously, for our community is something that is always the number one issue when you look at DDS's polling and things of that nature. But it's scary. It's taken me and my family, a year for us to be able to get my child to have general anesthesia so that he can get his teeth fixed. And that's going to happen in like 2 weeks. So not only am I nervous about the health summit here, I'm also nervous about that. And so I know when, we have procedures or things that we have to move forward with, it's extremely difficult for us as family members. And I think through this bill, as well as Dr. Glassman explaining it this afternoon, will be helpful because it's not only the child that's going through it, the family's going through it, and the community has to go through it because we have to change our entire week or a month and do a whole bunch of prep work for something that normally someone would just go in and do.
Right.
Whereas we change everything. So I really appreciate that. And with the limited time that we have, Jim, I want to thank you for everything that you've said. And I want to leave you with not only, our appreciation from Family Voices of California and our partnership that we have, but, the friendships that we've developed, and learning that you and my dad went to the same high school was extremely interesting to me. And, that we're worlds apart, me being here in the Central Valley and, you being up there, and we're still able to connect. And I think that's one of the things that the internet and Zoom and things like that have done for our communities, which is for all of us advocates and consumers to be able to connect with each other. And I think it's extremely important. And I just want to thank you for your time. And if you have any closing words, please, but otherwise, again, thank you so much.
No, and the collaboration that we've begun, Nick, is going to be, a opportunity for change, as you mentioned earlier. Again, I can't thank you enough for your involvement in the DISCO Advocate Day. All of those meetings were facilitated by you and your team. And we wouldn't have been able to do it in that fashion. I'm going to tell you that right now. So the Advocacy Day was a success because of your organization joining with us and the collaboration. I'm very proud of what you guys accomplish. We need more family voices in the world. And again, I mean what I say about any of the individuals that are on today on your summit, that if there's something that I can do, I'm on the website for the ARC. Please contact me if I can be of help of anything. I'm here for you. And again, you're the people that I admire.
Jim Frazier, thank you so much for your time, and we'll look forward to more conversations, and we will make sure that Jim's information is available to all of you. Thank you so much, Jim.
Thank you. You guys have a great summit.
Thank you.
Bye-bye.
All right. Well, I hope that was inspiring to all of you, because it was to me. And not to go over our time, because we have so much information to cover now. I'd like to go ahead and introduce Mike O'Day, who's going to be presenting on the enhanced care management, which is our first plenary of the day, to follow up our CCS plenary from yesterday. Mike's been a tireless advocate and has helped so much in regards to putting this together, a very complex system of care. We have some great people lined up. Mike, thank you so much for everything. I'm going to turn it over to you for your presentation.
Thanks, Nick. And first of all, let me congratulate you and the team on an amazing first day of the Health Summit. There was so much rich information and discussion yesterday, and I'm looking forward to what's in store for today. I'm honored to be moderating this panel this morning. My name is Mike O'Day. I am the Senior Director of Health at Children Now. If we can go to the next slide. Just a little bit about Children Now. We are a statewide policy research and advocacy organization, taking a whole child approach to building power for kids. On the next slide, one of the things that is a lot of my work, and one of the things that is a theme of many of the Health Summit panels, has been Medi-Cal transformation. So it's probably not a surprise that Medi-Cal is working to build a more coordinated, person-centered, and equitable health system that works for everyone. In California, Advancing an Innovative Medi-Cal, otherwise known as CalAIM, is a multi-year initiative to transform the Medi-Cal program and make it integrate more seamlessly with other social services. Next slide, please. One of the CalAIM policies is a new benefit called Enhanced Care Management, or ECM. It's a statewide Medi-Cal benefit available to eligible members with complex needs. It includes access to a lead care manager who can provide comprehensive care management and coordinate a patient's health and health-related care and services. The Enhanced Care Management benefit also provides connections to quality care patients need, no matter where they seek care. And like I said, the Enhanced Care Management benefit is new. It was only about 10 months ago when most children and youth populations became eligible for Enhanced Care Management. And so far, over 6,300 eligible kids have enrolled in ECM services. The benefit is available through Medi-Cal managed care plans, but services are provided through a network of community-based providers. And one important point is that Enhanced Care Management is intended to enhance and seamlessly integrate with existing care management services and programs like CCS. So it's not meant to duplicate or replace any existing services. But it takes a lot of work as the new kid on the block to stand up a new benefit like this and make sure that there are a network of qualified providers. So over the next hour or so, we will dig into how the new ECM benefit is rolling out for children and youth from different perspectives from our esteemed panel. So first, we will start by learning more from Dr. Pallav Babaria, who is the Chief Quality and Medical Officer and Deputy Director for Quality and Population Health Management at the Department of Healthcare Services. She will speak to what enhanced care management is, who is eligible for enhanced care management, and what the state hopes to achieve with this new benefit. Next up, we'll hear from Carly Myers, staff attorney with the National Health Law Program, who'll give us a look at the data on enhanced care management enrollment so far and what we know about the kids enrolled. She will also share important information and resources offered by the Health Consumer Alliance. Then parent advocate Jennifer McClellan will highlight the challenges families face in coordinating care for their children with complex needs and offer insight into whether the enhanced care management can help. Then we'll hear more about how enhanced care management services are being provided already, starting with the team from Children's Hospital Los Angeles, Dr. Mona Patel and Sarahi Garcia. Will share how they've worked together to provide enhanced care management services to the children in their care. And then we'll go up north to hear from another dynamic duo, Janet Peck and Amy Miles from Butte County Department of Public Health, who will talk about how they're working across their agency to provide ECM services for kids in the CCS program. And then last but not least, because the enhanced care management benefit is through the Medi-Cal managed care plans, we will hear a managed care plan perspective from Catherine Baresi, Chief Health Services Officer at Partnership Health Plan, which is a Medi-Cal managed care plan that serves members in 24 counties. So I am so excited for this discussion. We'll have time for questions at the end, so please make sure to drop them in the Q&A box. And without further ado, please help me welcome Dr. Pallav Babaria.
Thank you so much, Mike. Can everyone hear me okay? Perfect. Well, before I kick into the slides, I just want to say how honored I am to be here. I celebrated my 3-year anniversary at the Department of Healthcare Services recently, and presenting at this summit was actually one of the first things I did when I first started. And the feedback and conversations and dialogue that happened at that summit absolutely informed and guided the design of the enhanced care management benefit. So a lot of what I'm about to present today really traces its roots back to that conversation we had a few years ago. You can go to the next slide. So for those of all of you in the audience may have varying levels of familiarity with ECM. So I'm going to go through these slides relatively quickly so that we can get into the meat of our conversation with the rest of the panelists, but we will share the slides and there are really helpful links embedded throughout, which have much more detail than what I'm going to cover today. So enhanced care management is a statewide benefit that is available to anyone who is receiving Medi-Cal through a managed care plan. And as of January 2024, we estimate that almost 99% of all Medi-Cal members will be enrolled in a managed care plan. So this covers the vast majority of our population across the state. And ECM is really designed to be a comprehensive, whole person care, wraparound care management benefit aimed at really those individuals in our program, both children and adults, who have the most complex needs. And it's a cornerstone of CalAIM in really thinking about whole person care. And I know many of you in this room probably have lots of familiarity with different care management programs. We know that especially for our complex children and youth, many of them are enrolled in multiple programs and have multiple care managers. And the goal of ECM is to really be the person with whom the buck stops, who can really coordinate across all of our fragmented delivery systems, coordinate across multiple different care managers, and really take that burden that right now in our system is often borne by families and caregivers of navigating all the different services and people, and really be the person who does that so that burden is not borne by families. We have an entire spectrum of care management services that we have built out as a part of the larger CalAIM population health management program. So as you see here, ECM is really, at the top for the most complex individuals. And then there are other case management programs, including complex care management, that our plans are required to provide for members who maybe don't meet criteria for ECM. And then we also have really robust guidelines for basic population health management, which sets expectations of what our plans need to be doing for each and every single Medi-Cal member to really support wellness and prevention, as well as transitional care services. So what additional wraparound services are needed when Medi-Cal members are moving from settings of care, such as being discharged from a hospital or rehab. We can go to the next slide. So these are all of our populations of focus of who is eligible for ECM. You can read much more about this in our ECM policy guide. A few things to call out is that in general, for the adults who are eligible for ECM, they have to meet these criteria, as well as usually have some sort of medical or social needs. So if you are homeless and an adult, you also have to have an additional condition that gets you ECM. We very intentionally for children and youth took a broader criteria. So for most of these populations of focus, for example, children and youth, if they are experiencing homelessness, they are eligible for ECM. They don't need a second qualifying condition or a medical condition. Same thing with children and youth, who are eligible for specialty mental health services. As long as you are eligible for those services, you are eligible for ECM. You don't need a second health condition. And that is really DHCS acknowledging that the way that children and youth's needs manifest is different than how adults are impacted by some of these same situations. And we really want to start looking more upstream. And if we can really effectively meet the needs of our children and youth across the state and catch them earlier and intervene earlier, we know that there are health and other benefits for years to come. We can go to the next slide. The policy guide has much more detail about this, but there are 7 core ECM services. So every single member who is enrolled in ECM will be assigned a single lead care manager. Sometimes that individual is a licensed individual, like a nurse, and sometimes it is a non-licensed paraprofessional, like a community health worker. And it really depends on sort of what the needs of the member are and what population of focus they're in. But that individual is supposed to meet in the field, face-to-face with our members for this care management service. So it is not a robocall or a telephone that is coming. It is someone coming to meet the member and their family at home, if that is convenient, at their provider's office, or wherever the most useful and convenient location is based off of the member's needs. They're supposed to do outreach and engagement. They're supposed to come up with a comprehensive assessment and care plan for that individual that is member-centered. They're supposed to, as I mentioned, really bear the burden of that care coordination. So especially if there are multiple programs, multiple other care managers involved, it is this ECM lead care manager that should be connecting the dots and coordinating among all of those people. There are also, again, this is really about whole person care. So there's nothing that is health related that is out of scope. So the ECM care manager isn't just focused on physical health needs. They're also focused on behavioral health needs and social needs and coordinating referrals to various community and social supports. They also provide member and family supports and can do health promotion and health education. And then, as mentioned, also providing comprehensive transitional care if and when an individual is hospitalized or moving between different settings, because we know that is a really stressful time where there are a lot of new needs and changing needs and can be really complex for members. We can go to the next slide. So these are linked at the bottom. You can do a Google search for our CalAIM dashboard, and there is tons of data on all of the CalAIM projects. But if you follow the links for the ECM and community supports dashboard, we are now pushing out data every quarter from the department, so everyone can see how these benefits are rolling out. I'm presenting statewide data here, but we also have data down to the county and plan level so that you can get really granular based on where you reside. But our latest public data release showed for the first time what is happening with our children and youth populations of focus. So for ECM, this benefit for children and youth went live in July of 2023. So that's that last bar on the right. We did have some children who had been enrolled in ECM prior to that point, largely as a carryover from our whole person care and health homes pilots, as well as some of the eligibility criteria, for example, those experiencing homelessness went live a little bit earlier. But you will see between Q2, before the benefit went live, to Q3, when the benefit went live, the orange bar shows how many children and youth across the state received this service. So in the first quarter alone, we doubled the number of children and youth receiving ECM across the state, and we will be preparing to release Q4 data in June, and preliminary numbers are looking really promising. So we know that there is growth and uptake, and yet we also know that only a fraction of the kids who are eligible for this service are actually getting it today. We can go to the next slide. So this is a deeper dive. This is also all publicly available information. You'll see on the left, these are the subpopulations of focus of children and youth who are enrolled in ECM as of July through October of last year. And the most common reason they were enrolled is because they had serious mental health or substance use disorder needs, or they had complex needs resulting in avoidable hospitalizations or ED visits, as well as children and youth experiencing homelessness. I will flag the sort of bottom three buckets. We know and anticipate that almost half of the California Children's Services individuals have a social need and would be eligible for ECM. And you will see that number, 501, is a drop in the bucket. So we know there are a lot of CCS kids out there who are eligible for ECM and not yet connected to this benefit. Similarly, we know the policy is that every child involved in child welfare is automatically eligible for ECM. As of Q3 of last year, we only had 263 children involved with child welfare enrolled. Again, that is a drop in the bucket, and we know that there's a lot more children and youth out there who could benefit from this who aren't plugged in with the program yet. And then we have a very small number of incarcerated youth that are currently enrolled in the program, but we anticipate that number will grow when the Justice Involved Initiative and pre-release services go live over the next few years. The bar graph on the right shows how many provider contracts there are across the state. So the big takeaway here is our plans have been building up a network. They have hundreds and hundreds of contracted providers, each of which can serve many, many children throughout the state. And when you look at the bar graph on the left, there's a lot of unused capacity. So we have space, we have care managers ready, lined up to take care of these children. And one of the major missing links is getting these children and youth identified and referred to the health plan for the ECM benefit. We can go to the next slide. The next three slides we'll flip through, but these are all the resources and links. We can keep going. So there's a lot that we would love for you all to be involved in with ECM, and the links that we provided here include patient-facing information, plan-facing information, toolkits if you work with an organization that is interested in becoming an ECM provider, as well as more data if you want to do a deeper dive. But hoping we'll get into more details during the conversation with the panel. Thank you.
All right, thanks, Paula. That was great. Next, we'll move over to Carly Myers.
Thank you, Mike. Hi, everyone. As Mike said, my name is Carly Myers. My pronouns are she, her. I'm a person with a disability, and I am a staff attorney with the National Health Law Program. Next slide, please. Just first, a little bit about InHelp. We are a nonprofit law firm that protects and advances the rights of low-income and underserved individuals and families to access high-quality and affordable health care. We advocate, educate, and litigate at the federal and state levels with offices in California, Washington, D.C., and North Carolina. We have a number of partnerships with legal aid, disability rights, and health advocates. And in particular, here in California, we are part of the statewide Health Consumer Alliance. Next slide, please. So I'm here today to talk to you about whether children and youth are effectively accessing enhanced care management. And I think an important piece of that puzzle is understanding what the available data is telling us about the scope and areas for improvement and enrollment of kids into ECM. Next slide, please. Thank you. As has been discussed, ECM launched for most of the children and youth populations of focus on July 1st, 2023. And just a few weeks ago, DHCS released the first data sets that are inclusive of these populations of focus. They reflect enrollment data for the third quarter of 2023, which spans the first 3 months that the children and youth populations of focus have been live. Next slide. So the data shows us that a total of 6,339 kids under age 21 were enrolled in ECM statewide during this time period. This is in comparison to the nearly 80,000 adults enrolled. When we look at this in terms of percentages, we find that 93% of enrollees were adults and only 7% were children. Now, of course, because this is at the very beginning of the rollout of the children and youth populations of focus, we do expect their numbers to be lower than that of adults, many of whom have been eligible for ECM for up to 1.5 years prior. But the numbers are still strikingly low, especially when considering that there are over 5 million kids enrolled in Medi-Cal managed care. Next slide, please. So the data is also broken down by population of focus. As you can see, the highest enrollment has been for children and youth with mental health or substance use disorder needs, those at risk for avoidable hospitalization or emergency department use, and unaccompanied youth who are experiencing homelessness. More disappointingly, only 501 children in the CCS population of focus have been enrolled in ECM statewide, and only 263 children and youth involved in child welfare have been enrolled. And then the last 2 populations of focus listed here on the slide just launched statewide at the beginning of this year, so we don't have significant data on those populations just yet. Next slide, please. And then lastly, I wanted to give an overview of ECM penetration rates so far. So penetration rates, as used here, represent the percentage of all managed care enrollees who received ECM at any point in the last 12 months. Now, remember that not all managed care enrollees are eligible for ECM. They must meet the criteria for a population of focus, but it does give us a helpful point for comparison. The average penetration rates for kids under 21 across all California counties was 0.11%. This is in comparison to the average 0.65% penetration rates for adults across the counties. Next slide, please. DHCS very helpfully breaks down ECM penetration rates by county and by managed care plan. I've included here on the slide the 5 counties with the largest number of managed care enrollees under age 21. As you can see, there's a wide range of penetration rates, with Orange County as low as 0.05% and San Diego County as high as 0.66%, which matches the statewide average for adults. Next slide, please. And here you can see the penetration rates for the 5 managed care plans with the largest number of enrollees under 21. Again, relatively low rates across the board. Next slide, please. There is one managed care plan that I wanted to give a notable mention to, and that is Community Health Group, which serves San Diego County. CHG had a penetration rate that was more than double that of any other plan in the state. So it may be worth further research and conversation to see what they are doing so right. Next slide, please. And finally, I wanted to leave you with some resources related to kids' access to ECM. Next slide. First, I want to uplift the Statewide Health Consumer Alliance as a resource that we encourage families and youth to reach out to if you're having any trouble accessing ECM, or if you have concerns about the quality of your kids' ECM services or providers. The HCA provides free legal assistance in all languages and regardless of income level. I've included their toll-free hotline here as well as their website. Next slide, please. And finally, InHelp has released a number of resources specifically related to ECM for children and youth, as well as a wide range of other materials more broadly related to Medi-Cal services, managed care, and eligibility and enrollment. I've included a few of those on the slide here and encourage you to check them out if you have some time. Next slide. That's all that I have for you today. Please feel free to ask any questions. Thank you.
Thanks so much, Carly. Jennifer, I think, can we bring Jennifer on the screen? There are no slides, but would love to hear more from a parent perspective about enhanced care management and how it's landing.
Hi, let's see, Hi, my name is Jenny McClelland. My pronouns are she, her. I am the Policy Director for Home and Community-Based Services with Little Lobbyists. We are a family-led group that advocates for medically complex children and the programs that these children need to access care at home. So basically, we advocate for the kids who are the target population for enhanced case management. Some of my personal background is that my son, James, is 13 years old. He's a teenager. He has a tracheostomy. He uses a ventilator at night. He uses a feeding tube, and he has a rare skeletal dysplasia. In addition to all of that, he plays pit percussion in the marching band. He is a great student, and we are just normal people who are trying to make life work with a whole lot of complicated medical things going on. I did account for this meeting, and my son currently has 7 RN nurse case managers. That's separate and distinct from his enhanced case managers. When he was an infant, we were just having regular case management. And then when that wasn't quite effective, the state shifted to nurse case management instead, on the hopes that a nurse would be able to do things that a social worker couldn't. Now I'm seeing that we're shifting to enhanced case management. And I love it. I love the vocabulary words. I love that we are trying to make life work for these kids at home. As a parent, I don't really care what the terminology is. I just want it to work. I want goods and services to be delivered to him so that he can live the life he needs to lead. I've got a short story on how we've tried to wrangle case management to solve a problem. As you may be aware, we've had formula shortages for the last couple of years. It had to do with COVID and supply chains and manufacturing problems. As a mom, I don't care about the reason. I just know that we need his formula. So usually the way these things work is that the doctor writes a prescription for the formula the child needs and the medical supply company delivers it. Because of the shortages, we were having to jump from brand to brand almost every month. In order to get his enteral medical supply order filled every month, I had to call the supplier. I had to ask the lady to walk into the warehouse and count up how many pallets of formula she had. Then she would tell me what brand she could deliver. Then I would have to call his GI doctor to write a prescription for the brand that she happened to have. Then it would bounce to insurance for approvals. Sometimes the approvals wouldn't come back in time, and she'd lose the brand of formula that she had in stock at the beginning. So to do an experiment, I tried to assign that task to a case manager, right? It would be really great if I could delegate that task out. It seems simple enough. It just didn't work. It was easier for me to make 7 phone calls than for me to try to delegate making those phone calls to a case manager. And this is the food that my son needs to live. If he doesn't get this food, he can't eat. And so it seems like this would be exactly the problem that enhanced case management could solve. But when I tried to turn it into actual deliverable supplies, the formula that my son needs to live, it was just too complicated and too annoying to involve a whole another person in the process. The thing that I want enhanced case management to provide is measurable outcomes. I love that we're tracking how many kids are enrolled in the program. That's important. That's an important data point that's part of the problem. The thing that keeps these kids out of the hospital is supplies, medical supplies, prescriptions, delivered care. One thing that I've noticed is left out of enhanced case management is accessibility of private duty nursing. My son uses a ventilator. That means we need an awake and alert caregiver. We need a nurse in our house who is managing his equipment and keeping him alive. Private duty nursing is the single most effective piece of the puzzle to keep children who have medical complexity out of the hospital, and it's left out of the measurable outcomes of enhanced case management. I don't want to know that kids are enrolled in enhanced case management. I want to know that kids are in the program they've been assessed as needing a service, and that service is actually physically being delivered. And I think that we've built a really awesome framework, and I see so much hope for how this program's going to work. I just want to say, show me the services as mom. And I think we have a framework that we could build that into. I want to see measurables on the deliverables of the actual human beings who are providing service to this population. And I'm really excited to work with the state to make that happen.
Thank you, Jenny. Thank you for giving us some real concrete examples of what it's like juggling so many services and so many care managers. I'm excited to shift to our team from Children's Hospital Los Angeles to tell us how they're making it real and trying to deliver on some of those measurable outcomes. So I will turn it over to Dr. Patel and Sarahi.
Good morning, everyone. We're so humbled and privileged to be able to speak with you all today. So I'm going to first talk and give some context about the background of our hospital and the ECM program that we've developed. And then the real star is Sarahi, our community health worker, who's going to kind of really talk about the work that she does with our patients and families. Next slide. So really wanted to talk about from our lens as a health system, what CalAIM, ECM, and CalAIM in general has enabled us to do to build really intentional pediatric health delivery, integrating in the social needs along with medical complexity for the large volumes of vulnerable populations we care for. I will review some successes and some challenges that we have faced, and then really invite Sarahi to talk about the stories from the patient and family lens. Next slide. So we are a safety net hospital, which means that over 73% of the patients that we care for are Medi-Cal beneficiaries. And of that proportion, over 70% have CCS covered conditions, whether it's within our 27 specialty care centers we have, or whether it's admissions into our hospital, our ORs, and beyond. A very complex population that intersects a wealth of vulnerability as well. Greater than 60% of the populations that we serve have limited English proficiency. So when we started learning about the opportunity in CalAIM, for us, we were really excited because we thought, how can we sort of shift and start to change the way that we deliver care in that lens and context of how do we truly serve and link community services with the healthcare system that we have. Some of the CalAIM focused things that we have done is really start to impact and push our health-related social needs screening and thoughtfulness throughout our enterprise. Being able for the first time to hire community health workforce and integrate within our care team models. And then finally start to think about enhanced case management and what that means within the CCS complex care services we have, our child welfare systems, and beyond. Next slide. So health-related social needs screening. So the graphic on the bottom is sort of a quick, tiny lens into what we think about when we deliver care at Children's Hospital Los Angeles. What we're looking at is population-based, payer-agnostic, means any child and youth coming through the doors of our hospital or in the community that we are so privileged to care for, we will screen for health-related social needs. Our screening that we're looking at right now that we have developed over time is really testing the areas that you see here. So behavioral health, housing, food, utilities, digital access, transportation, and interpersonal safety. And asking the population, are any of these things that you have to manage that, and how can we help as that does intersect and impact your medical care? If we find that there is a positive, then again, without looking at payer, we are here to help. And what we've been able to do with programs such as CalAIM, we've been able to integrate team members to help integrate the social sort of risk case management on top of the integrated case management systems that we've had for decades. So our community health work team, it's been the first time in the past year that we've actually been able to hire community health workers as CHLA staff members, which is really exciting as a hospital system. What we've been able to do with our team of now 13 FTEs as we're integrating within our clinical team. So if we have a specialty care center, as an example, our community health work staff is right at the table in the clinic, huddling with the doctors, the nurses, the social workers, the nutritionists, the therapists, really having the thoughtful and intentional conversations about how do we care for that patient and family in front of us, and really trying to think about the depth of the community services. We as an organization have not been able to challenge and heal for the depth of vulnerability that our patients suffer for. And I think this is the first time we've been able to at least start to kind of think about this in an intentional way. Next slide. So since July 2023, we are contracted across 4 counties and 8 different managed care plans. The populations of focuses that we are contracted for include those that you see here. So the CCS population, our SMI and SUD, the child welfare population, and excitingly, since January, we're just starting to kick off work in the space of birth equity. And this graphic down here is a dashboard that we have internally of our enrollments that we have for different managed care plans, and you can see the colors are the different plans. I put this here for a reason, not to talk about our enrollments, but more to talk about some of the successes and the challenges that it has from an administrative standpoint when we're working with so many different managed care plans. Next slide. So the successes, I think, are incredible, and it's something that's been the North Star for us. So enabling our institution to hire community health workforce, integrating the team into our clinical care teams, having that intentional peer-to-peer support. It's a very different context when you have a Dr. Patel walking into a room and trying my best to grapple and understand with social needs, rather than a peer member stepping in and saying, hey, I understand, and let me help you. And being able to invite and engage in that conversation together as a team. I think the extension of the care that we're providing outside of the walls of our hospital system, and being able to go into farmers markets, being able to go to colleges with populations and enrolling classes together, being able to meet patients where they are. Sometimes it's in a Starbucks, sometimes it's at a McDonald's, and reinforcing people don't have to come to us to be able to get that care. And really starting to think about how do we intentionally reduce health disparities. I think that's really the exciting part. Now, some of the struggles that we have been facing and we're grappling with is, I think as a pediatrician, trying to adapt and advocate for a pediatric lens when it comes to enhanced case management. So a lot of times, we know that this program is a rollover of health homes, and that was an adult-based case management model, but intentionally thinking and realizing pediatric care and complex pediatric care is very different than adult-based care. Different rules, different goals, different interventions, different case management overall. Even, it's a small nugget thinking about the interplace of family and vulnerability and all of that and how that impacts child development. That's a very different thing that we have to think about in the delivery system. Referrals that we get from managed care plans for some sensitive populations. So we can think about our child welfare, SMI, SUD. We've had cases where we'll get a fax referral for a child who is referred to us for ECM, which we're excited to be able to help. But we had one situation recently that there was a suicidal ideation. We called the health plan. There was no additional information. And what we are asking is there a warm touch, a communication that can happen so we can better understand the referral coming in? Because there are very many delicate situations that I think a conversation is important. Challenges in enrolling the straight Medi-Cal and fee-for-service population, so specifically in our child welfare and some of our straight Medi-Cal CCS populations. We know since not in managed care may not qualify for ECM, so we're trying to grapple and figure out how to impact and do that work. And then I think the biggest challenge we have is that every MCP unfortunately has different requirements, different ways you document, different audit structures, different file formats and billing, changes in billing that happen. So from an administrative performance, it's been challenging as a health system to adapt and try to streamline the care. Next slide. So really, I wanted to introduce Sarai, one of our community health workers who specifically works in our bone marrow transplant team in our specialty care center, and wanted to invite her to talk about the real work that she's been able to do.
Good morning, my name is Sarai. So with the first patient that I wanted to talk about, he's a 9-year-old patient just going through bone marrow transplant. At first, the patient and the family did not say that they need anything. They stated that they were okay for the moment. And then upon speaking with the social worker, we were able to see that they actually did need quite a bit of help. So I was able to help build that rapport with mom. We were able to apply for a utility assistant program, and then we were also able to apply for CalFresh. So we're just waiting for that with mom. And then with the second patient that I wanted to speak about, he's a 14-year-old patient, also going through bone marrow transplant. Mom really needed a lot of help from the beginning, and really needed help navigating the system. She's not an English speaker, so I feel like that was very difficult for her. But now I've worked with her since August, I believe, and I've really been able to see her grow and feeling more comfortable and taking that self-advocacy and taking charge of the family care, and seeing her grow has just been really wonderful to see, and exciting to see as well. The challenges, so some of the challenges that I see, at least myself, with community supports, sometimes it can be very difficult navigating community supports and the processes for community supports. So that has been one of the challenges, and also the immigration population. There is lack of resources for a lot of them. So that has been something very difficult, trying to navigate the system and trying to be able to see how we can best help our families. And as well as the housing crisis can be very difficult.
All right, thank you. I think we'll be ready to answer questions whenever it's that time. Thank you so much.
Great. Thank you. Thank you for the hard work you guys are doing to try to figure this out and serve our families. Next, let's hear how Butte County is tackling ECM for kids with CCS.
Yeah, good morning. My name is Janet Peck. I'm the Senior Program Manager for Butte County, California Children's Services. I was a physical therapist for 6 years at the medical therapy unit before I was the program manager, and now been the program manager for 6 years. And we're just newly getting started with our ECM program. We will have Amy who speak after me. So I'm going to kind of give you the CCS perspective as to what happens for the referral side and successes and challenges that we've had with the program. So we started doing this around December, January of this year, that we started making the referrals to the program. We had a list of kids who we were excited to be able to do the referrals. And for those who may not be familiar, CCS is birth to age 21. So when I say kids, I may be referring to persons who are 18 to 21 years of age. We've found that the referral process has actually been very easy, I think, because it's internal within Butte County. We started using the form that our Medi-Cal plan has, and we make the referral either directly to the Medi-Cal plan using the form to the number on the fax form, and we will also send it to our plans or to our internal department, so that they have it through their confidential fax number. And that opens up a really easy chain of communication. We're actually in the same building, so they walk down to our offices and we can have a conversation with those referral if they need additional information, or if we have some sort of contact with a family, then we're able to relay that information to them. One of the things we've had, which is kind of a success and a challenge, is identification can sometimes be a little challenging. As you know, and I think it was Jennifer, the mother earlier, she brought out so many really good points of how there's overlap, but then there's also silos. CCS is responsible for doing medical case management for the CCS medically eligible condition. And so that is a nurse case manager, RN, who is doing that on the medical side of the house. And they're making a referral when they see social determinants of health that aren't being met. So it's not necessarily those medical components, because that's responsibility of CCS, although it may be somewhat related, like they need help with transportation. They can't figure out how to contact the Medi-Cal plan to be able to make that happen. And we've tried and tried. So it's more like we've tried to make it happen and it's not being successful. And we know they need a little bit more assistance, somebody to come alongside them a little bit more than what the CCS staff is able to do. So the referrals have to not be something that's part of the regular medical case management that CCS performs. And so, like I mentioned, it is services that either are very complicated, need maybe in person because there might be a language barrier or some sort of a cultural barrier to be able to help the family to embrace whatever services that is. With that, though, the family has to consent to want the services. And sometimes that is a challenge to explain to them that one more agency is going to contact them, one more agency is going to reach out to them, like the parent earlier mentioned, one more service provider who's going to try to help them. And I think sometimes that can be overwhelming for families, even though somebody may be trying to help. I think sometimes it's just so much for families. They're tasked with such a huge responsibility that even the thought of somebody helping is too much. So we have to receive that verbal consent from the family, and sometimes they turn it down. Even though we want it to happen, they have the right to decline it. And so we can't force them to have that. And so referral doesn't happen, and we'll document that. And then also CCS the staff may not be aware of what family is experiencing outside of their CCS medically eligible condition. You know, families aren't necessarily sharing that, and we may not always have contact with families. You know, we may only be doing their annual medical review and recertifying them and sending them on their way. And we may never talk to that parent. It's sometimes not even that we haven't tried, because sometimes we try multiple times to call parents and are not successful. So I think sometimes that can be a challenge. So we have found that the ECM staff within our county is extremely friendly. They're great to work with. We haven't had any issues on our end with our managed care plan. The referrals seem to go through, and that pathway seems to be clear, which is great. And I know Catherine Baresi is going to be talking about that a little bit. We're partnership in our county. And so in terms of communication, it really has been nice within our county because we already have those HIPAA authorizations to be able to have that conversation between entities within our county. So I think that has been really nice to have that part. And then one of our biggest challenges, I think, is trying to contact the families or the client that, you know, the phone number may not be a valid phone number, or we may not have a phone number at all, or we call and there's no voicemail that we can leave a voicemail, or they call and they see it's a number that they're not familiar with, and so they don't take our call. So I think that is some of our biggest challenges. So I'm going to turn it over to Amy so that she can talk about her side of the house with the ECM part.
Great.
Thank you.
Thank you, Janet. Good morning, everyone. As Janet put it wonderfully, I don't even know if I have to say much, but she covered all the bases. So it was kind of interesting how we first started accepting referrals from CCS, because our program didn't think we were quite ready, but one of the CCS nurses emailed us one day and said, you know, I think I have a kiddo that could qualify, you know, could be eligible for CCS. And it was just a very brief email and outlined, you know, some of the needs that the child and the family has. And I was like, yes, you know, this is going to work. So let's do this. We're just going to jump right in. And so I sent the referral form that Janet mentioned, that partnership health plan specifically created for ECM. And it's very simple, it's easy to use. And so that is one of our main referral forms. It comes, like Janet said, to our confidential fax email box where only 2 of our staff, including myself, have access to that. So it's very HIPAA compliant. And another referral form that we've actually created in-house, it can be accessed through a QR code. And so we have, we put the QR code on our flyers for the public, in addition to a 2-page flyer for when we educate different programs that might be referring to us. And so, of course, with the QR code, a person needs to have a cell phone, which a lot of people do. And it was created through Cognito Forms, and I don't know how many people are familiar with that, but it's a wonderful new technological thing that I think is fantastic. It's obviously all electronically. You fill out the form, you hit submit, and the form comes directly to our confidential fax mailbox. So we can access it and review it, and the referral is made that way. So we're pretty happy with that technology as well. As far as successes, obviously CCS has been great to work with, and it's been fabulous that they are also part of, you know, public health, Butte County Public Health. And like Janet said, you know, we have staff located in the same building. They can go have a quick chat. Otherwise, we can pick up the phone, or we can do a quick Skype, schedule a quick appointment if we need more information about one of the members that's been referred. So we're pretty happy with how that's going. And Janet mentioned the social determinants of health, because when we receive a referral, we need to have a TAR created for partnership health plan, treatment authorization request. And along with that, we have to have a social determinant of health code assigned to the member. And so we need to have as much information as possible so we can assign a code to the member. And so the beauty of working with CCS, again, is we're all under the same umbrella, and we can call CCS staff and say, hey, you know, you're more familiar with the family. What can you tell us specifically? You know, what are the needs? Is it food insecurity? You know, is it housing? Things like that. And so that's been one of our successes. Again, just that open communication with CCS. Another thing is, if, you know, we have an issue and maybe we can't contact the member, asking CCS, hey, what has your experience been with the family? You know, they're not replying to our phone calls. You know, maybe you could reach out to them and just say, hey, you know, ECM's trying to contact you. You gave your consent, you know, give them a call, or, you know, the next time maybe you see this phone number pop up, please answer it because it's ECM calling. Then as far as challenges, again, the phone the phone numbers. I can't say this enough. Those are a challenge. Not so much when we receive the referrals from CCS, but when we receive them directly from partnership, because on a monthly basis, the managed care plans do send us referrals. They may or may not have a phone number for the member. The phone number that we do receive may be disconnected. So it can be very difficult to contact the members. So that is kind of an overall challenge that we're experiencing, not specific to CCS though. So that's been our biggest challenge so far, I have to say. We do have a couple of ways that we can try to find a phone number for someone, which in a couple of instances that has worked, fortunately, but it's not always going to be the case. So then we resort to letters, which may or may not work. And we just kind of go from there. And we hope that at some point we can reach the member. And I think that's about it for right now until we get to what we're calling the rapid fire. So I just want to thank you for the opportunity.
Thank you, Jenna and Amy. I love to see the collaboration. And welcome, Catherine. Tell us more from the managed care plan perspective, how it's going.
Yeah, welcome. And thank you, Mike, for including managed care in the conversation. And really just, I hope everybody's having a great conference. As a parent with 2 youth with special healthcare needs, Family Voices holds a very special place in our family's heart. And so, but very excited to be here today to talk to you guys about the great work Partnership is doing under enhanced care management and the managed care's perspective as we look to improve the health outcome for children and youth with special healthcare needs in California. So a few things to touch on to kind of build upon what others have spoken to this point is what is Partnership doing? What is managed care doing to build this network? So we're doing everything. We're firing on all cylinders and to deliver these services in the community to these very needy families and kids who have strengths and resiliencies that we want to maximize. We're working with a lot of traditional and non-traditional partners, but to give you a bird's eye lens, this population of focus started, as you heard the department say, in July of last year. Partnership has over 140 contracted providers today who've raised their hand to say, we'd like to serve children and youth under enhanced care management, and we're very proud of that. All of them at various different levels of capacity, at various different levels of learning. And so to support that increased growth in services, we're looking to kind of wrap our arms around them through incentives and grant programs that we offer here at the health plan when you contract with us, dedicated teams and technical assistance. There's somebody that you can actually call as a contracted ECM provider and have a person. You're not going through a phone tree to talk to about billing and referrals or questions about rates or people that may qualify, because we know the quicker our providers are served, the quicker these kids are served. And to us, that's the most important piece. The other thing that I will say about our non-traditional providers, we are proactively going out and talking to them to say, tell us about your expertise. Tell us about what you do. We're not necessarily calling it case management, but multiple times we're having these, what we like to refer to as imagination sessions. And through the art of discovery, what we're finding is you're doing enhanced care management. That's exactly what the state has envisioned. That's exactly what we envision. So it's a lot of groups such as First Five. You've heard our wonderful public health and CCS partners at the table. We've also talked to childcare and Head Start, family FFA agencies for foster youth, and rural CBOs who often have staff who wear multiple hats to say, talk to me about what's working well for your families and your community and what you know and how we can support that, how we can create a revenue stream around that so that these services not only go away, but that you can expand to help multiple families and continue this great work. So very proud of the early starts for this and excited to see where this is going. Oftentimes, as I've seen and I'm watching the chat, families say, I didn't know about this. And questions that we get from our community partners is, how are you sharing this benefit information? How do families find out? What proactive activities are you doing to either facilitate, augment, support, and get the word out? And the truth is, again, just like network building, we're doing it in all ways here at Partnership. We have such a very big geographic area in the northern part of our state. But truth be said, it's a matter of meeting families where they're at. And it's oftentimes that we find one family who knows something, who knows another. So an example that I can give you is our Family Advisory Committee, who's made up of members, former youth on California Children's Services who've aged out, their families, their caregivers, regional center clients, and making sure that they're aware of these benefits, kind of almost as a grassroots effort. Think of it that way. We're working with our existing contracted providers. Partnership in 14 of our counties is a CCS whole child model plan. So we contract with all the specialty and tertiary care centers, making sure their social workers and their care teams understand ECM, the referral pathways, and inviting them into that space to say, and are you interested in providing this level of service to the clients that are coming through? And at community events, partnership, if we are nothing else, we are a community health plan. And we have a broad population health management team leadership who are out in the communities spreading the word at everything from, health fairs to farmers markets on weekends. They're dropping by provider offices, checking with pediatricians and developmental specialists to say, hi, here, we just want you to know that this is out there and how to connect our families into these resources. So there's no one right way. It's always all times for partnership. The other thing that we commonly have heard, and I really just want to thank Jenny for calling this out in terms of how are we going to measure this? How are we going to improve the outcomes? And this is something that partnership has been very laser focused on since the launch of ECM, not just for kids, but for the entire benefit. We have a built-in quality improvement program for ECM providers outside of the regular ECM rate and dollar amounts that our contracted providers get. We conduct routine audits on care plans, and we provide feedback and TA, resources for training support for case managers. But built within this quality program are benchmarks related to outcomes that they can pull down additional dollars for outside of ECM, because we want to incentivize actual services, actual improvement in quality of life and care. And we know that that's the intent that the state has with this benefit. So the program integrity component for partnership is also a huge piece. The other thing that we're looking at is really flexible models. I think, as parents, you've got those big binders and you've got contacts for all these different agencies that are touching the needs of your children or your loved ones. And the truth is, there's some really great new innovative ways in which those silo systems are now talking through enhanced care management. And I'll give you an example. One such example is recently passed, a McKinney-Vento Act required all schools to have a homeless coordinator assisting homeless family and redirecting them to housing needs. We have enhanced care managers talking with those McKinney-Vento Act liaisons at schools to say, if you identify a homeless family, refer them to me for ECM so we can help them not just with their housing needs once that referral happens, but also with their medical needs and other social determinant of health needs across multiple payers. Another great example is the one I started to describe with First Five and Head Starts, government-sponsored programs that typically see the young little kids early with developmental difficulties and families that struggle and challenges. And now they're at the table going, well, gosh, I think we should be talking to managed care. We should be talking to physical health. We should be connected in with community-based organizations. And how do we do that? And I'm just really, really excited through some of their home visiting programs. And lastly, with foster youth, they are another group that has typically multiple agencies between child welfare, FFAs, sometimes the attorney that represents them, the public health nurse. Getting a great model together for those teams to work cohesively around that family is another exciting opportunity that we're exploring here at Partnership. One of the other things, it all sounds rosy, and I will tell you, building new things is hard. Getting silos and systems to kind of dismantle, their information or stretch beyond what they're currently doing is hard, especially in a post-COVID environment where people are trying to get back to normal. Some of the challenges that we've seen, like I said, very proud that we have over 140 providers It's workforce, actually finding folks that have experience in serving these very vulnerable populations to raise their hand and say, I'd love to be an ECM case manager. And I think that's where community health workers, parent trained educators and liaisons could be magical in this space. The needs that we have geographically speaking in Northern California, we are a rural health plan by far and wide. And so what ECM looks like in these communities as a community-based case management endeavor, it's not uncommon for our families in the most rural parts of our state to live 2-3 hours away from a local provider, let alone a specialist. So working with technology, working with those communities to find out how they're getting care, what they're doing is where we really want to stand up their resiliency and build into that so that those communities are not left further behind as we innovate and build these great programs for youth. And then one of the elements we commonly hear, and again, I've seen it in the chat with regards to challenges, is duplication of services. What am I supposed to get under enhanced care management? And what is my public health nurse doing? And what is my regional center service coordinator doing? And how do I know who to go where for what? And where does all this funding come from? That's an area where partnership has really leaned in heavily to help our providers through what we call that imagination process so that they feel confident knowing where to bill, how to bill. And then the next phase is bolstering their confidence on explaining this to families. And for that, I'm really, really excited. I will say the successes that I've seen anecdotally on a patient and community level completely motivate and endeavor me in this organization to this work. I think pulling back even just a fraction of the load that these parents and families carry is well worth all of these challenges and the build out. So we've seen some incredible wins early on, and we just hope to continue to build on those. So I know that we've got more questions in the chat, and I'm excited to see where we go with the rapid response and Q&A. Thanks, Mike, for the opportunity.
Thanks, Catherine. While we're bringing our panelists on screen, I did want to uplift one question that was asked in the Q&A, and thank you for Carly for answering it, but I think it's really important. If families are interested in how to access the enhanced care management benefit, the best place to go is your managed care plan. They're the ones that can give you information about what is available. So self-referral is really important. So just wanted to make sure we uplifted that. So I wanted to take the moderator's prerogative and ask all of our panelists, if there was a magic wand, I mean, we heard a lot about the challenges that you all are facing, but if there was a magic wand, what is one change that you would make right now to ensure that the enhanced care management benefit for children and youth populations successfully meets their needs? So I know there's a lot wrapped up into there, but if you could answer in 1 to 2 minutes, and maybe we will start in the reverse order. So we'll start with you, Catherine.
I had to take a deep breath. I did a big diaphragmatic breath. I think a quick win was something actually that we heard from our Butte County CCS partners, these referral lists that the managed care plans send to all of our contracted providers. While data mining is great, this is still an opt-in program. And by far and wide, what we see, the people that say yes are the people that are already engaged in talking to these community level case managers and staff, people they know and trust. And I think a better referral pathway and identification would be best used by letting families put their hat and their voice in first versus just a cold call on a list.
Thanks, Catherine. Janet and Amy, our Butte team.
Yeah, I'll go first. So mine are actually fairly simple. One would be that families would have unlimited minutes on their phones, and that they would have a voicemail that always works, and that when they receive a message, they'd call in like an hour. That would be really awesome. And that, I think Catherine has mentioned it as well as I think Amy also, is providers. We need providers, we need, we're rural. And so it's great that we have a case manager who will help partner, but if there's not services that we can help partner and connect them to, then it makes it really difficult to be able to assist them. I think Catherine did mention it, that the majority of our providers are not in Butte County. Our families, we have 1,000 families, our children who are in our program, and they have to travel to Sacramento is the closest, but many of them are going to San Francisco, Oakland, Stanford for their care. And phone minutes. Oh, and that families would have like this magic ability that they wouldn't be overwhelmed by the heroic effort that they're doing to care for their children, because they'd have so much support around them that there wouldn't be an opportunity to be overwhelmed, that all their needs would be met. So that's what my magic wand would be.
Awesome. I'm going to go back to that valid phone number, or that working phone number. I mean, that's a big thing for us. But also I want to touch on the providers like Janet did. My passion has been children's oral health for many, many years. I was a health educator before I was in this role with ECM, and spent many years educating families about the importance of children's oral health. And the fact that our families, the vast majority of our families in our county, have to travel out of county for oral surgery to be provided to them is a huge thing. And I know we touched earlier this morning on the dental care aspect, and I'm really looking forward to Dr. Glassman's presentation, because I've been familiar with him since the mid-90s, and I can't say how important that oral health care is. And I know there's, all kinds of healthcare are important for our kiddos, but oral health is just my passion. And so I would love to see more oral health providers up in these rural parts of California.
Thanks for lifting up dental care. Dr. Patel and Sarahi.
So there are a lot of great community supports through insurances, which is great, but each insurance has different processes. It can be difficult to navigate. So if we would be able to have that same process and application across the board, I think it would really be easier for our families and for ourselves to be able to get those resources to them as quickly as possible.
So much has already been said from my list, but I'll lean into, I think, an intentionality in the program design for pediatric populations versus adult populations. I think a lot of what happens in even the documentation, in the care management principles and everything is adult-based still. When I talked about earlier on warm communication for very sensitive topics, I think that's an intentionality that needs to be interwoven. Pediatrics is very different than adult care. And I think that it is very important to be able to make sure that our clinicians, our families, our everything that's kind of always accounted for in pediatric health.
I agree with that. Jenny, the magic wand is yours.
I have a non-magic wand that is achievable. It just might be outside of policy. Even when people don't have phone numbers, they have social media. I'm middle-aged, I'm on Facebook, the young people are on TikTok and Instagram. They exist, they are reachable. You just have to think outside of that 10-digit box. If you want a model on how to do it, State Council for Developmental Disabilities is active online, they're active on social media, and they have workers who respond and answer questions. We have a lot of organic self-help mutual aid Facebook groups for all of these medical conditions, for all these programs, for IHSS and CCS. People are online and have formed communities, and they're answering these questions internally. What if they could actually speak to a real live social worker who could make contact? When people have to change their phone numbers because of poverty, their Facebook and their Instagram stays the same forever. If you want to find people, get online and stalk them and make yourself available in the places where people are.
What a great suggestion. Not the stalking, but the social media. Carly.
Yeah, thank you. I love that. I love that magic wand one. Yeah, I mean, I think one piece of the equation that needs to be talked about more is that ECM is exclusively a managed care benefit, and there are still over 300,000 children and youth under age 21 enrolled in Medi-Cal fee-for-service that don't have access to this benefit or to community support services. I think the issue is particularly prevalent, as has been identified in the Q&A, among foster children and youth, over half of which are not enrolled in managed care. And, while I understand that there are complicated considerations when a family, a social worker, or a youth is deciding whether or not to enroll in managed care, if they have that choice in their county, I also think there needs to be a better way to not leave the kids who are arguably most in need of this benefit behind. So whether that's, waving my wand to fix some of the barriers and complications that deter youth from enrolling in managed care, or coming up with some alternative solution, I would say I just want to make sure we're not forgetting about the children and youth that don't even have that threshold eligibility for ECM right now.
Absolutely, Carly. And that's something that I've heard a lot in my conversations around ECM. Paula, we'll give you the wand.
It's so hard to choose one. So I'm going to try to wrap everything up. I would say in my dream state, every single child and family that needs ECM is aware of it and can access it in a simple, streamlined way. And that when they do get the benefit, it is of sort of the quality and comprehensiveness that is our goal, and recognizing that's not our reality today, but that's what I want the future state to be.
Great. Well, with that, let's open up for some questions. Kristen Rogers, I see your hand is raised, so maybe we can start with you if we can unmute you, Kristen.
Sorry, I didn't realize my hand was raised.
Oh, okay.
I did not have a question. Sorry about that.
No problem. Looking at the chat, I'm wondering if we can tackle this question that asked, is there a list of ECM providers? There's someone who works at Kaiser and UCSF who have not heard about enhanced care management for pediatric patients. So just as families can call their managed care plan, if providers are interested in referring some of their patients, who should they call?
Great question. And I think there's some related ones around like who are the ECM providers. So we have a requirement that every single managed care plan has to have on their website information about an ECM and how that referral can be made, whether that is a member or family referring, themselves or their child, or a provider. And so the easiest way is to go to the website of whichever managed care plan that member belongs to. And I usually Google name of managed care plan, ECM, and you will get to the website that has instructions. There are some health systems who've created their own internal workflows, whether that is an order in Epic or something that goes to their own social workers and case managers. So if you work in an organization, asking how your organization is accessing CalAIM benefits is useful, but it always lives on the managed care side. And we also have a requirement, and it's usually through the provider portal, but Catherine can correct me if I'm wrong, that all managed care plans have to list their entire contracted network of ECM providers, as well as identify what specific populations they serve. And so if you want that roster, that is also available on all the plan websites, and DHCS is monitoring and double checking that that is getting, is posted and is getting updated regularly.
Great, thank you.
And then
so I'm sorry.
I saw it in the chat, so I'll just address it right now too. And I think, some of our the other panelists spoke on this. We 100% recognize that in current state, the referral process is different from plan to plan. Doing batch referrals is hard. The information isn't standardized. Some plans have lots of follow-up paperwork. And so as a part of the department's ECM and Community Supports Action Plan that we rolled out last summer, really informed by lessons learned from the first year and a half of the program, we are actually working to streamline and standardize what the entire referral process looks like statewide, so that we can streamline and eliminate a lot of that local variation. And for those of you who are super interested, we have a public population health management advisory group meeting next week where we will be revealing draft recommendations to streamline referrals. So encourage any of you who are interested to join that public meeting and provide your feedback.
Fantastic. Paula, where can folks find information about registering for that meeting? Is that on the website?
It is, and I'll drop it in the chat in a second.
Okay, great. There were a couple questions about specialized training to provide the care management, as well as training and eligibility for community health workers. So curious if anyone can illuminate some of the pathways around training and qualifications.
I'll go ahead really quickly. So our program is a non-clinical program, which I think is kind of important because some of the ECM programs have clinical staff. They're staffed by nurses, some of them, but we are non-clinical. And so our staff has lived experiences. So along with that, and I don't want to specifically say exactly what they are, but we've also done a lot of trainings in regards to complex care management is one of them, trauma-informed care, home visiting training, focusing on safety, what to expect, things like that. And I was trying to think off the top of my head what might some other trainings be. What do you call it? Oh gosh, motivational interviewing is another one. So again, not towards that clinical, but just more of, how to relate to people and, get a conversation started about how you can actually help them. As far as there are specific trainings to become a certified community health worker. Our staff hasn't done that, but I hear they're absolutely wonderful. So, and I think there's also trainings for specific to peer support where you can become a certified peer support specialist. And one of our staff has actually done that in her prior role with a different employer. So.
I can comment a little bit about what we've done at Children's LA. So we created our job code and structure and job description and everything when we embarked on creating a position, really looking at the guidelines that the state has put out on eligibility, lived experience, the number of hours and all of that. And then we have been working pretty closely with a community-based organization for many years called Para los Niños. They've helped us with grants in the past in developing training curriculum. It's been healthcare and the CBO together over many years. Our social work teams, Para los Niños, advising with a group of 4 promotoras that we've been able to develop a curriculum. So as Amy mentioned, motivational interviewing and how do we kind of adjust when we have workforce in a health system now, and then also bridge the community-based resourcing and all of that. So our curriculum is evolving, iterating. We're constantly learning, but it's been in partnership with one of our aligned community-based organizations.
Fantastic. Anyone else want to weigh in on the training qualifications question?
This is Catherine from Partnership. Just one thing I will add, just as a different lens to this, we've funded through our incentive payment plan grants to our contracted ECM providers, additional staff training, not just initial, but ongoing, and have made recommendations. In the first launch year of 2022, we actually paid for a majority of our enhanced care management providers to come out to a national conference that was held in Sacramento. And part of that ongoing support and auditing that we do of care plans is to redirect them to whether it be state available resources on DHCS's TA website, but also some evidence-based case management resources and literature to help bolster those teams as well.
Excellent. Rick Hodgkins, I see your hand is raised. Can we unmute Rick?
Yes, I am so glad I was able to finally unmute. Maybe my question from yesterday can be answered. Thank you so much for this. I'm glad that I'm glad many parents, for those parents with children getting you know, they may have to go to Stanford or UCSF to get, you know, specialty. They may get primary care like in a rural or a rural county, but that they have to go to Stanford or UCSF or some other center for excellence for specialty care. I have to do the same thing as well. I live in Sacramento County, and my primary care team is at UC Davis, which is where I go as for the first front line of defense. But I go to Stanford or UCSF as a last resort, kind of like how we deal with, you know, how we should deal with all things. Speaking of Cal-AIM, I'm actually on another webinar on my phone dealing with ICFDD, something that a future health summit ought to deal with. The question I had from yesterday, and I posted it on the chat, is Sacramento County a CCS county whole child model? So that's my question from yesterday. Thank you.
I don't know if anyone can.
No, this is
Thanks,
Catherine from
Catherine.
Partnership. No, it's not. It's still a classic CCS county.
Thanks. Please feel free to drop questions in the Q&A box or raise your hand if you would like to ask anything. But I was going to ask, where did that question go? Okay, Ben, it's in the chat. Ben had asked, is there guidance from the state on training requirements to standardize what skill ECM interventionists must have? So, Pallav, I think you'd mentioned standardized referral form. I think Ben's asking about standardized training requirements.
The short answer is no. There's not specific guidance or requirements right now. I do think, you know, a number of the panelists spoke about this. There's a number of comments in the chat about this. We knew that we as a state did not have a lot of experience with the children and youth population in ECM. As was mentioned, they were not a huge part of the health homes and whole person care pilots. And so all of those sort of multiple years of what is the right care model? How do we do this effectively? What training is needed? I think that is still knowledge that we as a state are developing with this population launching. And so a lot of the initial focus has really been the nuts and bolts, as you saw. How do we get contracts in place? How do we identify the providers? How do we make referrals streamlined? But we acknowledge that what that doesn't address is the variability in the quality of services being provided, as well as the knowledge and skills of the lead care manager. And we are, for ECM, a lot of our monitoring has been on sort of that utilization and uptake. We are now starting to pivot to the quality questions. And so over the course of the next 6 months, my team is looking at quality indicators. We actually have a robust project going with some fantastic researchers and academics at UCSF who are helping us with some of this work to think about what are those right outcomes measures? How are we going to know, is this ECM doing anything, right? Because at the end of the day, if that care manager is not actually solving the problems of the child and youth, actually getting those services rendered, it's pointless, right? All of this is pointless. And so we are actively working right now on identifying what are those outcomes measures and quality indicators that we want to monitor, both for the adult population, but as mentioned, that one's easier because we already did that once in our whole person care and health homes evaluations. For both children and youth and our long-term care, we don't know what those right outcomes are that we should be tracking. So we hope to, you know, sort of work on that through 2024 and starting in 2025, really be able to laser focus, say, this ECM is working and this is not. And so I saw a few people in the chat. Anyone who is interested in that topic, please sign up for our PHM listserv because we will be doing stakeholder engagement through that advisory committee over time. And if you have ideas or wish lists of what you want to see, please send that to me directly, and happy to take all of that feedback and to incorporate it. And I think the training will come out of that as well. And so we need to get to a place as a state for children and youth where we can say, these are the best practices, this is what works, this is what doesn't work. And once we have more of that knowledge, we definitely intend to sort of add requirements and make those standards statewide. We just don't want to do that prematurely until we actually know what is and is not working.
Great. Thanks, Pallav. I see Nancy, you have your hand raised.
Thanks. Hi there. Thanks, Love and everyone. I so appreciate the work that's being done on ECM, and I'm delighted to hear about the follow-up on quality measures and competencies. And was just thinking and reflecting that with the different populations of focus, especially with populations coming out of regional centers or CCS, that there may be a need for ECM workers to have different core competencies to really understand the landscapes in which families are living and navigating, and wondering and hoping that at some point that there might be a role for people with lived experience to contribute to developing those competencies, and also working with the state on the development of and UCSF on the development of those quality measures. And just also real appreciation as a mama who's got kids in like literally like 4 populations of focus. And doing some work on the ground with ECM providers. I'm really excited about the future of ECM, and just really am looking forward to and inviting and asking for the opportunity to include caregivers and young people who are going to be receiving the benefit in the development of the next phases. So thank you so much.
And I'll just say, Nancy, you're spot on. And I think that also resonates with some of Carly's great points in the chat, that we know what makes ECM for children and youth partly complex is it's not a monolithic population of focus, and the needs are different. And it is unlikely that one provider is the best provider for all populations of focus. And so how do we get to that care model that is like unique and tailored to the specific needs of that subpopulation is a major challenge. And so definitely committed to partnering with you all at the state level over time. But I also think that partnering with the plans in the short term is a huge opportunity. So as Catherine mentioned, all of the plans as a part of the new Medi-Cal contracts are required to have consumer advisory councils that really include Medi-Cal members and families to inform all of their services. But especially, I think in the ECM world, there's a lot of direct feedback that plans can get. And I know our plan partners, they want to get to that point where, there's also a lot of questions about how do you get a good ECM provider and not a bad ECM provider? And our plans want that feedback. They want to know like who's not doing a great job that maybe they need to coach and support or work out of their network, and who is doing a good job where they can maybe help that organization build capacity. And so for all of you, I think the more that you can engage with your local managed care plans in the short term, that will really help us scale up and improve this program.
Great. Well, I think that is a great last word. I want to thank all of my panelists. This was a fantastic discussion, and I want to appreciate all of your hard work in transforming this huge system of Medi-Cal that is so important for our families. So with that, thank you, everyone, and I will turn it over to Nick.
Thank you so much, Mike, and everyone that was on the panel. I know it's a labor of love to go through and explain such a complex system of care. And Mike did an unbelievable job of bringing together consumers, parents, all with very powerful stories, and be able to answer questions. And again, the ones that we couldn't get to, they're all being compiled so that we can send them out all at once to not only the providers, but to the parents, and they can answer. And then we'll go ahead and send those back to you. You just have to give us some time to compile everything. We are going to take a break right now. We're coming back just like we did at 11:45 last time to hear some words from Assemblymember Joaquin Arembula. Again, please go ahead and log back on at 11:45, and we will hear from him. And then after that, our breakout sessions start. So just like yesterday, you pick the one that you'd like to go to, and we will be off and running for the second part of the second day of the Family Voices Health Summit. We appreciate all of you being here. Go take a break.